Hi, my name is Rachel James-Eason, and today we'll be talking about pulmonary embolisms. According to the American Thoracic Society in 2017, pulmonary embolisms contribute to between 5 and 10% of deaths in hospitalized patients. In the United States, more than an estimated 1 million people have been affected by pulmonary embolisms each year. A pulmonary embolism occurs when a clot or a piece of a clot travels from an extremity through the venous circulation and into the lungs. Once in the lungs, these clots can cause serious complications such as respiratory failure and death. According to the Mayo Clinic in 2018, surgery is one of the leading causes for blood clots, which then turn into pulmonary embolisms. Following major surgeries such as joint replacements, bedridden patients are at an increased risk for major complications such as pulmonary embolisms due to immobility. In addition to pulmonary embolisms, immobility while hospitalized can also lead to pneumonia. The combination of pulmonary embolism and pneumonia can lead to even more serious complications, such as acute hypoxic respiratory failure, in which the alveoli in the lungs are not able to perform gas exchanging effectively. In my presentation, I'll be talking about the patient named Jane Doe, an 80-year-old female who developed a pulmonary embolism and pneumonia following a total hip replacement. Following a fall at her home on October 27th of this year, Miss Jane Doe was seen at the emergency room and diagnosed as having fractured her right hip. She underwent surgical replacement of the joint and was kept in the hospital for observation following surgery. On October 29th, less than 24 hours after her surgery, Mrs. Jane Doe experienced sudden dyspnea, sharp chest pain, and a cough with bloody sputum. She received a chest x-ray which revealed pneumonia and a CT scan which revealed a pulmonary embolism. Her pulse oximetry levels plummeted into the 60s and supplementary oxygen was provided. Because of her hyperventilation due to hypoxia and pain, Mrs. Jane Doe entered a state of respiratory alkalosis. Respiratory alkalosis is characterized by a low partial pressure of arterial carbon dioxide, or PaCO2, which is then followed by the falling of the partial pressure of arterial oxygen to fraction of inspired oxygen ratio, or PaO2 to FiO2 ratio. The normal range for arterial PaCO2 is 35 to 45. Mrs. Jane Doe had a PaCO2 of 22. The normal range for the PaO2 to FiO2 ratio is above 300. Those with a value less than 300 are considered to have an acute lung injury, and those with a value less than 200 are considered to have acute respiratory distress. Mrs. Jane Doe's PaO2 to FiO2 ratio was 235, meaning she had an acute lung injury and was on her way to respiratory failure. Treatment for pulmonary embolisms includes surgical and non-surgical management. Non-surgical treatment includes supplemental oxygen therapy and drug therapy. Oxygen should be applied via nasocannula, face mask, or in more serious cases, mechanical ventilation. Drug therapy for pulmonary embolisms focuses on breaking up current clots and preventing future clots. Heparin and warfarin are the drugs most often used. Heparin works quickly, therefore is used first. Warfarin is began on the third day of heparin use. The heparin is continued until the patient has an internationalized normalized ratio, or INR, of 2 to 3. Mrs. Jane Doe only required oxygen supplementation via mask, then nasal cannula. She was begun on heparin on October 19th and began warfarin on November 1st. Her INR reached 2.8 on November 5th, and her heparin was discontinued. She required no surgical interventions. In cases where surgical interventions are required, embolectomy, which is the surgical removal of the clot through use of a catheter, is used. In addition, a filter may be placed to prevent further embolisms from reaching the lungs. According to St. Joseph's Hospital Department of Medicine in 2001, some cases of pulmonary embolism are benign and treatable with no long-term consequences. However, some cases can result in sudden death within minutes. They also state that in some patients who receive antithrombotic therapy, there are complications of recurrent non-fatal embolism, prothrombotic syndrome, and chronic thromboembolic pulmonary hypertension. In the case of Mrs. Jane Doe, she fortunately had no long-lasting complications and no long-term effects related to her pulmonary embolism. She completed antibiotics for her pneumonia and was able to come completely off oxygen after 2 weeks of treatment. Ineffective breathing pattern, risk for bleeding, and impaired gas exchange are all nursing diagnoses which apply to pulmonary embolism. Ineffective breathing pattern can be related to hypoxia, chest pain, and anxiety. There is often dyspnea, tachypnea, use of accessory muscles, tachycardia, hypoxemia, restlessness, and an oxygen saturation of less than 90%. In order to help the patient, the nurse can position the patient in a sitting position, which allows the lungs to fully expand. She can administer oxygen as prescribed, and she may provide reassurance to alleviate anxiety, as well as assisting the patient with coughing and deep breathing. Risk for bleeding occurs because of the anticoagulant therapy used to treat pulmonary embolisms. Nurses must administer these medications exactly as prescribed and assess often for signs of bleeding. Because of the obstruction of the lung tissues during a pulmonary embolism, there's decreased perfusion and impaired gas exchange. There's often confusion, restlessness, hypoxemia, hypercapnia, tachycardia, dyspnea, headache, and an oxygen saturation less than 90%. Nurses must monitor vital signs, administer oxygen therapy as needed, and position the patient to provide optimal lung expansion. The patient and the family education focuses on new medical condition and the treatment surrounding it. They often have inaccurate information, have questions for the health team, or inaccurately follow through on instructions that they were given. The nurse will need to assess their knowledge of the disease, including its severity, prognosis, risk factors, and treatment. In the case of Mrs. Jane Doe, she was provided information on immobility following surgery and how that led to the development of both her pulmonary embolism and pneumonia. She was taught to perform leg exercises, to use compression stockings, and to stay hydrated. In addition to pulmonary embolism prevention, she was also educated on anticoagulant therapy. She was taught not to use a razor with a straight blade, not to take any new medications without consulting a doctor, not changing her diet of foods high in vitamin K, and to avoid herbal supplements. Mrs. Doe and her family were taught the signs and symptoms of pulmonary embolism and to seek medical treatment immediately if symptoms occurred. Following her fall at home, hip fracture, pulmonary embolism, and pneumonia, Mrs. Jane Doe made a full recovery. She suffered no long-lasting respiratory complications and was able to be discharged from the hospital after 15 days to a skilled rehab facility. She continues to receive physical therapy to strengthen her hip and is now able to transfer herself without assistance, stand, and walk with a walker. She is expected to be discharged home later this month to the care of her family. And this completes my presentation.